Yes, warm welcome everyone. Thanks for having me. So who knows that song, even though it was just short? Yes, see some hands there and there. Yes, that's from the well-known series Sex and the City. Today I call it Sex and the Island. And I remember back 20 years when watching it the first time, because I watch it now the second time, but back then it was a huge outrage when there was a series about 4 women talking openly about their sexual desires, their sexual problems, and yeah, coming to today, nowadays, sex is everywhere. Social media, advertisement, movies, but still, when there is like a failure of a functioning sex life, this is still a taboo topic. Nobody talks about it. No social media, no movies, and also in the doctor's office, we don't ask specifically for it. But it is our responsibility to talk about it. So if you just take one thing home today, that it is to address sexual health issues, and I would be happy. So obviously I have a little bit the same problem like Dr. Jeffrey before. I already was well introduced. But still, for those who don't know me, I'm an OBGYN consultant at Doctors Hospital and also work at Cayman Fertility Center because I'm specialized in reproductive medicine. But throughout my career, I developed a special interest in addressing sexual health issues, and especially with a background of reproductive medicine, meeting couples that somehow have problems, whether it is by conceiving, but also figuring out that there is a high need for women to talk about sexual health issues. Back in Germany, I implemented like a special clinic once a week where I just saw women that had somehow sexual health issues like painful intercourse and so on. So yeah, I really think it's important to address that and to get more awareness about sexual health issues. So that is why I'm happy that after all those great talks we already had, where it was in this afternoon session all about creating awareness for different kinds of things, I'm happy to move on with sexual health issues from my side in females, and afterwards I will hand over to my colleague Dr. Pramud, who will cover a little bit like the endocrinologist side of it. So yeah, that brings me to my next slide, that I remember back in university that the professors always told us, if you want to do like a comprehensive health visit, you should always at least once address, is there any sexual function issue? Because that sexual health concerns are usually multifactorial. So if we ask for it, we may find underlying conditions and can help patients with problems like diabetes, mental health issues, and so on. And on that slide, you see it's obviously gynecological issues, but it could also be a history of sexual abuse or other medical conditions, like I said, diabetes, fatigue, stress, or what we heard with Dr. Jeffrey, menopausal symptoms that lead to sexual dysfunction or could be risk factors for sexual dysfunction. And it's quite common. Just like, for example, pain during sex is said that there is an appearance throughout lifespan between 14 up to 40%, which does not mean that it will affect everyone, but it could be that there is a lifetime or an episode in life where it impacts your health and where it impacts your life quality. And we, by asking for it, we create a safe space. So that brings me to this slide, to see that we as healthcare professions should include a simple question with our consultation. It could be that it's just an easy question like on our intake forms asking, is there any sexual health issue you'd like to address today? Or me, I just had implemented it with my first consultation. When taking a medical history, by the end of it, I'll ask, is there any sexual health concern you'd like to talk about? And even if there's not immediately a response, but you offered your patient the opportunity to maybe come back to you and say like, look, doctor, you asked me last time, and yeah, now 3 weeks later, here I am, and I really think there's something I'd like to talk about with you. So really giving them the opportunity, and you as the healthcare profession talking about that taboo topic like GSM, pain with intercourse, erectile dysfunction and all that, brings it back on the table and brings the opportunity to talk about. Today, I'd like to have a closer look on sexual dysfunction in females, and there, especially in pain with sexual activity. What is sexual dysfunction in females? It's an umbrella term, and as you see, it covers a lot. It covers lack of sexual desire, impaired arousal, inability to achieve an orgasm, or what I just said, the pain with sex. So for the sake of time, this is what I'm going to focus on today. And obviously, I have to share the stage with my valued colleagues, so I also try to stay in time. And here you see different terms that are associated with pain with sexual activity. And the tricky part here is that there's a huge overlap. And to make it a little bit easier for you, I like to highlight today one of the most important ones. So I wanted to address vaginismus, or how we call it nowadays, pelvic floor muscle hypertension, and vulvodynia. So vaginismus, or pelvic floor muscle hypertension, is an involuntary contraction or some kind of a muscle spasm of the pelvic floor muscles, making vaginal penetration difficult, painful, or even impossible. And here you have to see it comes from it's a muscle-related condition. So symptoms can be pain or burning sensation during penetration, which could be just an gynecological exam, or even tampon use. And it is a reflective tightening of the vaginal muscles. On the, for you, left side, you see a picture of the pelvic floor muscles, where you just see the pelvic floor muscles. There are multiple pelvic floor muscles, but just like, it's really like a bathtub where our organs lay in our pelvic. And when they tighten up, you see, it affects the bladder, it affects the rectum, and it affects our uterus and the vagina. So that explains why, okay, when this tightens up and is tensed, penetration is really, really difficult. So what are the causes? Until today, why people develop vaginismus, I stick with that term because with sexual health professions, it's still like the most common used term. But the causes are also here, multifactorial, could be psychological factors, medical conditions like menopause or infections, chronic infections, or even a learned response to pain. So I will never forget my first patient I saw with vaginismus when trying to figure out, okay, when did it start? So that was a 40-year-old woman telling me, yeah, so I had multiple colposcopies and they took a lot of biopsies from my cervix. Nowadays everything is fine, but every time that was so painful. And then a couple months later, when she did her third colposcopy with taking biopsies of her cervix, suddenly she couldn't have any more intercourse with her partner because the pelvic floor just tightened up. So you see, okay, she had a traumatic experience, and this is now her learned response to the pain. So that just as a case report, which I always remember. And that brings me to the treatment options. And going back to that, this Women's Health Conference today is all about collaborative approach of helping women. I think vaginismus and the other condition I'm going to talk about really sums up that we have to work together. Because if you look here at the treatment options, it is the pelvic floor physiotherapist, it is the CBT, it is the patient doing vaginal dilators at home to get back into personal control, and it could also be medical interventions like, for example, Botox or certain medications. But the most important thing is for us as healthcare providers to understand this condition is not made up in the head of the woman. This is an actual condition. And when you do a physical exam and you do a vaginal examination and you feel the pelvic floor muscles in a patient that has vaginismus, you see her pain and you feel yourself just with your little index finger that the pelvic floor muscles are very, very tensed. And by just pressure, put a little bit pressure just inside the vagina on the pelvic floor muscles, you see in her face how painful that is, and you sometimes even have the feeling, oh, maybe my finger is gone now, because it is so tense that you think like, okay, it bit in my finger, the vagina bit in my finger. So yeah, it is a measurable condition, and we have to educate our patients about that it is something that could be treated. But the treatment, as you can see, is a collaborative approach where it is all about reprogramming the body's muscle response. So, while vaginismus is a muscle-related condition, coming to the other condition I'd like to talk about, so-called vulvodynia, this is a condition that is based on a hypersensitive nervous system. The most common form of vulvodynia is the so-called vestibulodynia, which just means that it is a certain part in the vulvar area, especially the part of the inner side of the small labia and the entrance into the vagina. And there you also see how can I diagnose vulvodynia. Vulvodynia obviously is caused by a nervous dysfunction or hypersensitivity, sometimes caused or often caused by a trigger. That could be a vaginal infection, herpes infection, fungal infection, and then an ongoing burning sensation, chronic vulvar pain, or irritation. And as soon as we ruled out that there is not an acute infection that we can treat, and we see it's somehow chronic, meaning the sensation the patient experiences over 3 months, and we don't find any identifiable cause, we call it vulvodynia. And by testing it with a so-called Q-tip, we point with a Q-tip and in that area when we do a physical examination, and when you look into the face of your patient and you just tip the area, you also see that causes the pain, the burning, and they often have pain even by long sitting, riding a bike, horse riding or anything, and then obviously also discomfort during intercourse, tampon use, or as I said, sitting. The treatment options here are similar to the treatments with vaginismus, but on top of it, since it's not coming from the muscle, it comes from the nervous system. We also can work here with topical or oral pain medication, but also with medication that has an impact on the nervous system. So for example, antidepressants or anticonvulsants. Here it is also important, besides educating our patients about the condition they have, to also educate them, look, we try some medication here that is, wow, this time thing is really, putting really a lot of pressure. Taking this as an opportunity for a treatment, for example, by working with antidepressant lotions or ointments and educating your patient, look, we use those kind of medication not because you have a depression or something. No, we work with those medications because they work on a nerval base. So, but it is obviously a condition where you have to see the patients on a regular basis. You have to do a follow-up. Me personally, I see patients usually then the first time after 6 weeks and try different treatment approaches, and then again after 3 months and 6 months. And I must say, every vulvodynia patient I had back in Germany, usually after 1 year, you don't see them anymore because we tried, we found something, they did a multifactorial treatment, and somehow they are then educated on their condition and they found a way to live with it or to treat it and to get into a better space. So it's really teamwork, a follow-up, and an education of patients that is necessary. Also here, pathophysiology is still not fully understood, but with 8 to 12% of prevalence, it's nothing that we should ignore. We should address these kind of conditions in women experiencing those symptoms. Just quickly, since I just have, I think, 1 minute, a little going back to the beginning where I said, okay, I ended up developing interest into those conditions, especially due to my reproductive background. I have a nice case report, my first one here on Ireland, where I had a patient with severe vaginismus, already in treatments, ongoing treatments with pelvic floor physiotherapist, mental health problems, but also treatments. And there was on top with a couples therapy now the wish for a child. But when you have severe vaginismus, how easy can you do penetrative intercourse and get pregnant? That is really difficult, and it puts another pressure point on top of it. So for her, I offered her, like, consider insemination at home. Do a sperm collection of your partner, go back into your safe space, use your vaginal dilators, your pelvic floor muscle exercises at home, and perform a self-at-home insemination. And now she's pregnant, and the pressure is taken off the whole treatment of the vaginismus because we did not put it back on top of the vaginismus that is already putting a lot of pressure also on the couple itself. So to sum up, sexual dysfunction is multifactorial, multicausal, and it affects women and men. And we have, by us starting the conversation about it, we are not only improving the quality of the life of our patients, but we are also sometimes identifying underlying conditions like diabetes, cardiovascular diseases, or hormonal imbalances. And that is why I'm honored now to hand over to my valued colleague, Dr. Pramod. And thank you all for your attention.